welcome to our live stream today. My name is Anissa Mitchell of PMD Alliance, and today we're going to be talking about non-visual hallucinations. Many of you have heard us talk through some of our live streams about hallucinations and delusions, and we've learned a little bit about the visual and auditory things that you might experience. It can include maybe seeing animals or people or hearing music, but today we're going to be talking about maybe some of the lesser known or maybe lesser experienced hallucinations that Dr. Hermanowicz is going to be reviewing some other ways that you might experience these hallucinations. So with us, it's Dr. Hermanowicz. He's a movement disorder specialist. He's with the Eisenhower Medical Center in Rancho Mirage, California. And we were actually just talking about the beauty of California. And I think the first slide, you're going to get a lovely shot of what it is he gets to see at the beaches over there. So I welcome Dr. Hermanowicz. I'm going to pass this over to you.
Okay, nice to be here. Nice to be with everybody. I'm going to just pull up my slides and see if I can.
Oh, and remind you, if you have a question, please put it in the chat. And then when we get through with these, we will come back to the questions.
Yeah, so this is me. These are my slides. This could be California, but it is not. I'll let you guess later where that picture was taken. Just to orient everybody who's not familiar with California, I don't know if you can see my pointer or not, but I'm down here. Here's Palm Springs and here's Indio, and Rancho Mirage is right in between Palm Springs and Indio. Just a little bit northwest. I hadn't noticed this till I looked at the map, but a little bit northwest of the Chocolate Mountains. I'm going to have to visit the Chocolate Mountains, I guess, which is due east of the Salton Sea. Maybe that's where the salted caramels are coming from. And this is a picture from the parking lot of where I work. I took this during the winter months. I liked the juxtaposition of the palm trees with the snow-covered mountain to the west of the parking lot there. And this is what brings a lot of people to Rancho Mirage, the Palm Springs area, especially during the winter months. It's the golf. I think I may be the only person who lives here year-round who does not play golf. It's a golf lover's dream place, I guess. A lot of golf courses all over the place. To get oriented, talking about the topic today, I thought it would be helpful to see, well, where have we been and how do we arrive where we are now and where are things going regarding this topic. And as you may be aware, James Parkinson, a London physician, published his little monograph in 1817 describing a handful of patients. I think there are 6 or 8. Some of them he observed just walking down the street of London. And he was very perceptive and talked a lot about things about Parkinson's disease, including non-motor manifestations, difficulty with swallowing, difficulty with moving the bowels, constipation, for example. Really didn't touch upon the so-called psychosis symptoms, the hallucinations. This is his house taken some years ago. All those children standing out front, maybe each one of them had picked up a stone and broken a window. I'm not sure they're standing in front of their handiwork or not. This is the house more recently. Now there's a plaque outside his house. James Parkinson, physician and geologist. He had a lot of interest apart from medicine. His father was a physician. I think his grandfather was a physician. He lived in North London where he worked and lived in that same place that you see a picture of. He has a fossil named after him. This is the man who attached James Parkinson's name to the disorder that we now talk about, Parkinson's disease. He was a French neurologist, Charcot, in the subsequent generation following James Parkinson. And he is often credited as being the father of modern neurology. And here is Charcot with one of his presentations to his students and other physicians attending the hospital in Paris. And standing behind Charcot to his right is a fellow named Joseph Babinski. And if you know neurology, you've heard of the Babinski sign, where somebody scratches your foot and watches where your toe goes, up or down. This fellow here in the apron is Georges Gilles de la Tourette, who has a Tourette syndrome named after him. And this fellow next to the window back here with the mustache is Charcot's son, who Charcot insisted go into medicine. He did not want to, it was not his choice. And when his father died, he left medicine and became, this is what Charcot used to use to treat people with Parkinson's disease. On the left, you see the vibrating chair. Charcot had noticed that people who arrived in coaches over the cobblestones of Paris and vibrating on the way to their appointment seemed to have improvement of their symptoms. And this concept of vibration has persisted. It was tested again by a group in Chicago at Rush Presbyterian some years ago without any clear success. And more recently, a vibrating glove has been tested at Stanford in a small number of people to see if that may be helpful to the people with Parkinson's disease. I'm not sure what that cap is supposed to do, but maybe that's an early version of deep brain stimulation, which is certainly a component of treatment of Parkinson's disease these days. This is Charcot's son in later years when he left medicine and became a naval explorer, which was his first love. And his ambition was to be a naval explorer, gave up on medicine. Here he is exploring later in life. Here is his boat docking in the coast of Iceland, where his explorations and his life came to an end. He was trapped in a storm and he drowned off the coast of Iceland when he was in his late 60s. Here's a picture of Iceland close to where that occurred. So just so we're all on the same page about definitions, psychosis, which to me it conveys a lot of emotions and different meanings to different people, but psychosis is just a general term that encompasses hallucinations and delusions, and they can be with or without loss of insight, meaning, that person sitting in the chair who's not really there, I recognize that they're not real. I recognize that they're not, that is in fact a hallucination. That is insight. Unfortunately, when these occur in Parkinson's, as time passes, that insight is often lost. Hallucinations are simply an abnormal perception. There's nothing there, but people sense something is present, either a visual sense or an auditory sense, as was mentioned, or other senses can be involved as well. Any of them, in fact, can be involved, creating a hallucination. An illusion is something slightly different. Technically speaking, an illusion is an abnormal perception. You're looking at a lamp and you think it's a cat, or you're looking at a coat rack and you think it's a person. There actually is something there, but the perception is different than the reality. A delusion is something entirely different. A delusion is an idea that is not factually correct. A delusion is, there's somebody coming to deliver something to my home, or there are people waiting outside to break in and steal my collection of seashells. That's a delusion. That's not a hallucination. And they also occur, although less so, in Parkinson's disease. And we'll talk about that also a little bit toward the end. The idea of psychosis in Parkinson's disease is not a new one. This has been around for a very long time. The publication on the left-hand side of your screen, I think is from 1954, from actually an internist. He was not a neurologist, but an internist published this paper. He was in Rhode Island most of his career, originally from Chicago. And he described hallucinations and also delusions occurring in a woman with Parkinson's disease who was taking a form of medication which we don't have or use anymore, but it belonged to a class called anticholinergic medications. There are some of those medications, Artane, for example, or Cogentin. These are both anticholinergic medications that are still around and were the mainstay of treatment of Parkinson's disease prior to the arrival of levodopa. They are well known to be a contributing factor in some cases in people having psychosis symptoms, delusions, and hallucinations. And in the case the fellow on the left is reporting, this woman who did not have them before, did not have any problems with cognition to any great extent before, when she started taking this medication called Pagetane, sounds kind of like Artane, thought there were people around. There was a masked burglar in the basement of her home. needed to summon the police to get the master burglar out of her house. And on the right is a paper by Oliver Sacks and his colleagues talking about exactly the same thing. This is from 1972. Levodopa was just coming on the scene. Levodopa was actually FDA approved in this country in 1975. Its initial use was, I think the first reported cases of use of levodopa were in 1971. And Sacks was involved with that early on. And early on, there were these reports of people having hallucinations with the introduction of levodopa. But just looking back, Chris Getz and his co-authors did a review of older literature, and hallucinations were established as occurring prior to the arrival of levodopa, as we just saw in that previous paper. So it's not actually a new phenomenon that is just being discussed lately. It's been around pretty much since people have been treating Parkinson's disease. And there's also the idea out there that these symptoms are side effects of medications. Well, they really are not. They have been reported to occur in people who are untreated. This is a publication out of Barcelona some years ago, 7 years ago, in which 50 people de novo, means newly diagnosed patients with Parkinson's disease, an average age of about 69. And they were asked, are you having any kind of symptoms like hallucinations? And about half of them said yes. Well, it's 42%, I'm sorry. Compared to controls that did not have Parkinson's disease, only 5% of people reported hallucinations. Most typically, these were a symptom of presence. There's somebody there standing beside me or just out of my field of vision. And several of these patients reported these symptoms before their diagnosis, and even sometimes before they had their first motor symptoms, before they noticed a tremor or stiffness or slowness. And this was a publication out of London some years ago, where they reviewed charts of people who had passed away, and it had post-mortem examinations of their brains. They had brain autopsies to see, well, what was their true diagnosis? Was it Parkinson's or something else? And on review, several of these patients did not, in fact, have Parkinson's disease. They had other things. They had things that kind of looked like Parkinson's disease, like progressive supranuclear palsy, which is what Linda Ronstadt says these days that she has been diagnosed with, not Parkinson's disease, or that comedic actor Dudley Moore, if you remember him, he was ultimately diagnosed as having progressive supranuclear palsy, which kind of looks like Parkinson's disease, especially early on. It can be hard to separate them. But if you look, all these patients were treated with levodopa, but the great majority of people who had these other things, cortical basal degeneration, no hallucinations, progressive supranuclear palsy, only 7%. So even though they're treated with levodopa, they don't develop hallucinations, as do people with Parkinson's disease or people who are diagnosed with this other, well, it's not really an other thing, Lewy body dementia that many of us, including me, think is just a part of Parkinson's disease. People have looked for, well, what are the risk factors for people with Parkinson's disease having these kind of symptoms? And you can find people on both sides of the fence for things like age or age of onset. Yes, older patients are more likely to get them. No, they are not. These are the kinds of things that cause fistfights to break out at the meetings that I go to. Are women more likely than men? Yes and no. There has not been any discrete clarity about whether men or women with Parkinson's disease are more likely to have these kind of symptoms. For the duration of disease, there's some literature suggesting that duration of Parkinson's disease is another risk factor for these things emerging. There was a study out of Australia years ago, multi-center study based in Australia, where they followed people over time, the same set of patients over time, up to 20 years after living with Parkinson's disease. And they found that after 20 years, about 75% of people with Parkinson's disease would report having visual hallucinations. But not everybody agrees with that assessment. Motor severity, how difficult the difficulty that people are having with their motor symptoms of stiffness and slowness and and tremor, for example, does that correlate to the likelihood of having hallucinations of any kind, not just visual? And people are, again, yes and no. We don't know for sure. Mood disturbance, something called REM sleep behavior disorder. That's the RBD, which is fairly common in people with Parkinson's. And some people say, oh, yes, clearly a risk factor for developing hallucinations, but that's not been borne out by everybody's examination. And although a lot of people will claim that, oh, dopamine agonists like pramipexole, also known as Mirapex, or ropinirole, also known as Requip, are more likely to be provocative hallucinations, that is really not borne out by all the studies that have been published. So it's not clearly a certain medication type or clearly the amount of medication that people take that is going to be more likely to bring these symptoms out. Personally, I feel that these anticholinergic medications, and I count amantadine among them, amantadine has anticholinergic type qualities to it, are more likely to be provocative for these kinds of symptoms. I remember very well, I think it was the first time I encountered this when I was doing my fellowship at the University of Michigan. I gave one of my patients an anticholinergic medication because they're often touted as being especially good for tremor. The evidence supporting that is not exactly existing, but that's what everybody says. I'm not sure that it's true. So I gave my patient, there was a fellow, a youngish fellow, an anticholinergic medication to see if that would help more with his tremor than levodopa. And he called me up after about 2 days of taking the medication and said, I'm seeing people in my house. And that really got my attention way back when, 30 years ago. Usually when these things occur, and they don't occur to everybody with Parkinson's disease, but they often do. They're not rare in Parkinson's disease. And typically when they begin, they are visual. People are seeing all sorts of things, animals. One of my patients out here in Rancho Mirage, I remember some time ago said, well, I saw an elephant in the house. And his wife said, our house is not large enough for an elephant to be inside the house. And he said, well, it's a baby elephant. I've heard all sorts of animals, a nice dog in the kitchen, a cat on the chair. Sometimes they're pleasant. People kind of like seeing the animals, but sometimes, like the elephant in the house, that would not be so nice. But typically they're visual, seeing children. I've heard that many times. In my experience, more often it's a little girl rather than a little boy, but it could be both. I remember a woman some time ago was seeing a group of children in her home that she didn't like because they were sitting on her white sofa and they had muddy feet, which she found very disturbing. So the visual hallucinations are oftentimes the earliest type of hallucination that will occur when people have these kinds of symptoms. But as time goes by, it can involve all of the senses, other senses as well as vision. This was, again, studied in Chicago at Rush Presbyterian with Chris Getz and his colleagues, and they had a major role in defining these symptoms and also addressing how to treat them. And in the top graph, you see that at baseline, nobody had hallucinations. So they followed a group of people with Parkinson's who, over the course of 10 years, and at baseline, they had no hallucinations. And then half a year later, about 10 to 15% of people had hallucinations. And they increased over time. The percentage of people having hallucinations as time went by increased. But in the second graph, you see that people who had just visual hallucinations, the percentage is steadily decreasing. So initially they're all visual, and then as time goes by, they're no longer solely visual. And in the bottom graph, you see people are having mixed visual and non-visual hallucinations, and that percentage over the course of time, over the 10-year period of study, increases. So it starts out solely visual, and then as time goes by, it includes other senses as well. Unfortunately, they don't tend to just go away. Now, here's an interesting, I think, comparison. This is a paper from a group in Australia where they did a literature review looking at non-visual hallucinations in Parkinson's disease and what were people reporting in terms of the frequency. And it's all over the place. You see auditory hallucinations anywhere from 1.5% to 72%. And that's true for all of these non-visual hallucinations. Some people report a very low frequency, and some people, 73%, 72%, even 22% with tactile hallucinations, which I'll give you an example of in just a moment. But I think this reflects one, probably the patient base that's being examined, and also perhaps the techniques by which these numbers are being arrived at. Are they talking directly to patients? Are they just reviewing charts? How are they asking patients and their family members the questions about these hallucinations? So you get a very broad range about how frequent these things are occurring. That's a waterfall I visited some years ago. Oh, and a flower field. So some examples I thought might be helpful in illuminating this a little bit more. So presence hallucinations. This is exactly what is meant by that. Hey, there's somebody just beside me or just behind me that I don't see, but I sense that they are there. And this is, I think, the most common hallucination that people experience with Parkinson's disease. In fact, I think everyone, even those of us who don't have Parkinson's disease, have had this feeling at some point. There's somebody there, there's nobody there. But one hears it very frequently. I hear it very frequently from my patients at the time of diagnosis, and I hear it very frequently. I would say the majority of my patients at some time have had this feeling that there's somebody there who is not, in fact, there. They don't find it necessarily disturbing, maybe a little bit alarming, but it doesn't usually cause them to react in a negative way or call the police, for example. And by say what, I'm referring to auditory hallucinations, which are probably the second most common after visual hallucinations. And here are some examples. Some time passed, I had a very nice older couple in their 80s. So she had Parkinson's disease. She stayed at home with her husband, who was her full-time care provider. She needed a lot of care. She had rather severe and advanced Parkinson's disease. She needed assistance with her dressing, getting on and off the toilet. He would take her to the table and sit her down and provide her with meals. So his days were really taken up with his wife's care. He was devoted to her. They'd been married for a very long time, 60 years or more. And I recall later, during the course of her diagnosis with Parkinson's disease, she was hearing conversations, and they were unfortunately unpleasant conversations. And she told me that she heard a conversation between her husband and his girlfriend, that she thought he was hiding downstairs in their home. And she could hear them talking. And I asked her, well, what were they saying? And she said, I hear the girlfriend telling him, you spend too much time with your wife. He was spending all of his time with his wife. And that was very difficult for both of them. For one thing, she felt, in a sense, he's betraying her. This is outside of their marriage. They've been married for 65 years or whatever. And now he's got a girlfriend that he's hiding downstairs. And of course, it was very painful for him as well, because as I described, his life was his wife's care. He was devoted to her in every way possible and was determined to keep her at home and determined not to have additional caregivers in their home. It was a big job, really too much for any single person, but that was his life. And so this unpleasant symptom was very hard on both of them, as you can well understand. Another fellow I saw had a not so unpleasant auditory hallucination of when he would turn on the shower, he would hear music like a chorus singing. One could say, I guess, this is a form of illusion because there was a sound there, but he misinterpreted it as music playing. He didn't find it alarming necessarily. He found it strange. He found it, I guess, unpleasant in the sense that it was a reminder that he had Parkinson's disease, and he didn't want any more reminders that he had Parkinson's disease. And it did not evolve into something more troubling or threatening to him. He was not hearing conversations or voices. It stayed just the phenomenon of this feeling of hearing music that was not unpleasant. And he kind of recognizes choral music from an opera, for example. This third case was unpleasant. It was a woman I saw who was hearing Christmas carols. She was, I think, in her 70s, late 70s, as I recall, and she was hearing music playing, and it was distinctly Christmas carols, and it was happening pretty much every day. And you think, well, Christmas carols, those are kind of nice to hear, but every day. And I must have said something about Christmas carols. So that was kind of nice. And she said, well, it's July and I'm Jewish. Why am I hearing Christmas carols in July? She did not like it. She found it troubling and bothersome, and she didn't want it to continue. Very interesting fellow, I knew from the past, was having an olfactory hallucination. He was smelling something, and it did not smell good. He thought it was his house. It's actually somebody I knew out here in Rancho Mirage. And he thought the house smelled bad. And despite his cleaning and his wife's extensive cleaning of the house, taking all the stuff out, cleaning it, cleaning the closets, cleaning the bathrooms, the bad odor continued. He had, in fact, convinced his wife to sell their house and move out until I told him, you can move, but the odor goes with you. The odor is a hallucination. It is the Parkinson's disease contributing to this so-called olfactory hallucination. He, in the end, decided not to move out, not to sell his house, which is a good thing, because I'm sure wherever he was going to go, it was going to go with him. When I say take your butts elsewhere, I'm referring to people who smell cigarette smoke. There's somebody outside the house smoking cigarettes. I've heard that many, many times over the years. Not pleasant, kind of threatening. Why is somebody standing outside my bedroom window smoking a cigarette? And similarly, I have had patients tell me that they feel that there's a fire, they're smelling smoke. Not cigarette smoke necessarily, but something is on fire, which of course is alarming to them. I've had other people tell me they smell things strangely or smell them different from what they actually are. These are not terribly common. And for that reason, I haven't listed a lot of examples from my personal practice. And something I saw just a week or so ago was a tactile hallucination. I've seen this many times, and maybe some of you have as well. I was seeing a relatively new patient. I think I'd seen him once before. He's had Parkinson's for a while, some years. And I went to start the examination, and the motor examination of Parkinson's disease, as many of you are aware, is finger tapping, hand opening and closing, alternating hand movements, all that sort of thing. And when I said, okay, well, I'd like you to do this, the first thing he did was he did this. He took up something, he had something in his hand, and he put it into his left hand, and then he tapped with his right hand. I said, okay, now do it with your left hand. And he took this stuff and he put it into his right hand. And then he ultimately put it down on the examination table next to him. I've seen this numerous times where people feel like they have something sticky in their hands. And I've seen exactly what that fellow did, where they kind of roll it up into a ball and they try to set it down. That is a tactile hallucination. Another person I saw, woman I saw here, was having an unpleasant tactile hallucination, in the sense that she felt people were touching her. And she felt that she was being touched in places where most people are not allowed to touch, in very personal parts of her body. And she found that unsettling, to say the least. That persisted, and she would, even when I'm talking, oh, there it goes, I felt it. I've only heard that from her, but the tactile, the sticky fingers, I've heard many times, I've seen many times with people. It's not California. In the last of cases I wanted to bring up, these are not hallucinations, these are delusions, which are uncommon, but I thought it worth mentioning during this presentation. The more common delusions that one encounters with Parkinson's disease fall into a couple of categories. They fall into jealousy or a sense of infidelity, which is most unfortunate. It's kind of like the woman, she thought her husband was hiding a girlfriend downstairs. Accusations that, oh, my spouse is carrying on with a neighbor, or people who've had hired caregivers. My spouse is having a relationship with a hired caregiver that's improper, inappropriate, and so forth. Also, people are trying to harm me in some way. They're trying to hurt me. They're trying to poison me. The medications that they're giving me are not medications, they're poison, or somebody's trying to steal my stuff. Those are the more common delusions I hear from my patients with Parkinson's disease. Less commonly I hear, but I heard this the other day from one of my spouse of one of my patients. He thinks I'm somebody else. He thinks that there are more of me than one. There are duplicates of me, or thinks that there are many people with my same name that are in the home. Some time ago, I published a couple of these patients, their case reports in a journal. One of them thought that his spouse was a coworker, and the other one thought that her spouse was her mother, which they both found, the spouses of my patients both found this very unsettling, especially the fellow who was said by his wife that he was her mother. That brought a whole new dynamic into their relationship. And he said, I don't know why, I don't really look like her mother. He had long hair and a ponytail. He was an older fellow, but had long hair and a ponytail. He said, maybe it's the long hair, but this was unsettling. Both of these cases did respond to a medication, which I provided to them, which is why I published those two cases. So when these things happen, what is their treatment? Whether it's a visual hallucination, an auditory, olfactory, or tactile, what can we do? Well, if somebody calls me up and says, all of a sudden, my husband, my wife, they're having a lot of hallucinations, so they're really increased in frequency and they're more threatening, I want to make sure there's not something else provoking them, like a bladder infection. It could be something simple. I've found all sorts of things over the years that could be contributing factors, infections, or somebody introduced a medication, another doctor or provider gave them a medication that was playing a role in bringing these things out. So I want to make sure there's not, doing a urinalysis is a fairly simple thing. You got to come into a lab or take the cup home and provide a urine specimen back to the lab. And it's a fairly simple thing to do. People are falling. I found a couple of cases of people who fell and they had some bleeding on top of their brain, and that was a provocative factor. And also, as I mentioned, other medications, sometimes prescribed for overactive bladder. For example, oxybutynin, which is also called ditropan, is an anticholinergic medication, which could be a provocative factor. If people are having hallucinations, if I have the ability to reduce their medication without compromising their mobility, then I will. But in most cases, I'm stuck. I'm not over treating them. I don't really have a lot of wiggle room to cut back on their medication. So if that is in fact the case, then I really can't take away something without compromising their ability to get up from a chair or getting out of a car. And if the psychosis symptoms are persisting, which unfortunately they tend to, they tend not to go away on their own unless there's something else like a bladder infection provoking them. And unfortunately, as time goes by, we know they tend to be persistent and they tend to become troubling. And in that scenario, I intervene with medication. There really are only a couple of medications that have been proven to be helpful. Clozapine, which has been around a long time, it's an old medication. All those medications you see in the slide are classified as antipsychotic medications because they are known to reduce hallucinations and delusions. Clozapine, over the years, I've prescribed many times, but what a nuisance it is. You can only get the medication a week at a time. You have to do a blood test every week. Somebody has to go to the lab, the patient has to go to the lab and get the blood test. I have to check the lab, the pharmacy has to check the lab, and then they'll dispense the medication. So it does work. There have been 2 good trials, probably in Europe and the United States, that show that it does work, but it's a huge nuisance to use. Olanzapine has been looked at. It's also called Zyprexa, is the other name for olanzapine. And unfortunately, I still see some people arriving that they've been prescribed olanzapine for people with Parkinson's disease. Not a good idea, because it was studied years ago and it worsens the motor symptoms of Parkinson's disease. It's not a good choice. When I see that, I invariably take people off that medication. Quetiapine, also called Seroquel, has been around also for years and has been very commonly used. But really, we don't have convincing data that it's going to be effective. And I like convincing data that it's going to be effective. Clozapine has that, and so does the last drug, pimavanserin, which is also called Nuplazid, which has, in fact, received FDA approval for the treatment of Parkinson's psychosis. So all of these medications, they have a serious caution about increased risk of death and use of an antipsychotic medication in elderly people who have dementia. So I use them with some carefulness and caution, but these are the choices that we have these days. And I think that's, so this is just to remind me to say, if these things are occurring, you know, these are warnings of trouble that may come. And I tell my patients to heed those warnings. I want to know if they're having hallucinations or if they're having escalation of their hallucinations before they fall off the cliff, before things get out of hand. I don't want my patients showing up in the emergency rooms with these kind of symptoms. That's the last place you want to be. They really don't have a good way to deal with this, and you don't want them to get to that point. So I didn't used to earlier in my career, but I do now have a conversation. Those people who are my patients know very well that I ask them pretty much every time at the first visit and all subsequent visits, are they having these kinds of symptoms? And if they're there, how often are they troubling? And if they're there, I want to know if they're changing over time. This is an African proverb I like. If you want to go fast, go alone. If you want to go far, go together. I think that's why support organizations like the Parkinson's Movement Disorder Alliance is a good thing to have support. And that is pretty much my last slide. So if there are any comments or questions, I'm happy to hear them now.
We do have several questions, and I just want to say I love that you interspersed all these beautiful scenic pictures in this. It's kind of a nice little mental break. So,
any guesses where the pictures are? Any guesses where they're from? It's not California or Oregon or Hawaii.
You had a photo in there of what? Iceland, New Zealand, somewhere.
It's Iceland, yes.
Iceland.
These are all Iceland, my wife's home country.
That's awesome. I think we all need to go now because the scenery is absolutely beautiful. So thanks for sharing that. It's kind of nice to have that. So I do have a few questions, and one of them came early. It was interesting, and it was, it looks like the care partner was writing in regards to her husband, who thinks that he has seen every movie they watch, or if they're waiting at the light, if there's bicyclists there, that they're every single time they stop at this light, it's like living a deja vu. Have you seen hallucinations that seem to appear as though it's a deja vu? And honestly, can you explain what a deja vu is? I mean, I think we all know what it is, but like, what is going on that causes people to have a deja vu?
Well, people have speculated that deja vu, which all of us have, I've been there before, I've heard that before. I think all of us have had at some point, is the brain accidentally engaging parts of the brain that are involved with memory. Oh, I've heard that. That sounds familiar. And I'm trying to think if I've had people tell me, people with Parkinson's say that they've had deja vu over and what was the guy? Was it Yogi Berra says it's deja vu all over again? I don't recall any of my patients saying specifically that they're having recurrent deja vu. It sometimes also occurs with seizures. I'm not saying that person has seizures, but it's been associated with seizures that are activating that part of the brain of memory, probably in the temporal lobe, as a non-motor manifestation of epilepsy. But I could hypothesize why that would occur, but I don't remember hearing it from patients.
Okay. So you've given us quite a few different examples of hallucinations, and some of them sound like they could be somewhat pleasant or benign, but then others are not quite so benign. We had someone say that they see spiders and snakes that aren't really there. And I don't know if this person likes spiders or snakes, but most people don't like spiders or snakes. And that seems like it could be very upsetting to people. Is that common, or is that a part of maybe progression of the hallucinations?
It is part of the progression. And I cited Chris Getz and the people at Rush in Chicago who did a lot of this basic work. They really enlightened us about these kind of symptoms over the years. And Chris and his colleagues reported some years ago, published, that the term benign hallucinations should be removed because they may start out that way, but almost invariably, they don't stay that way. So the little nice dog in the kitchen sleeping by the stove, that becomes a stranger in the bathroom, or may become something ominous and threatening. So they tend not to be benign anymore. So we should probably not use that term to describe these symptoms in people with Parkinson's disease. They're a warning, like that sign you'll fall off the cliff if you're not careful. They are a caution of things that may be coming, and I pay serious attention to them.
So since you're talking about this, when someone does admit that they're having a hallucinations, but they still have insight, do you recommend they treat it right away or wait until it becomes more bothersome?
I don't, but that's tricky because there's no discrete timeline about when they could evolve into becoming threatening. And I sadly had, one of the reasons I changed my behavior over the years is that I did have patients who showed up in the emergency room. And that's a place you don't want to be. I mean, the end result is that people get medications that are not necessarily helpful, but means they can't go home. They get an antipsychotic, which is probably not good for them, called haloperidol or something similar. Then they get admitted to the hospital, and then it all comes apart. So I don't want that to happen to any of my patients. So it's a fine line. When do you think about taking another medication? None of my patients are pilled out. They don't want anything more. Enough, doctor, thank you very much. But recognizing that these things can become the top of the list that torments not just the person with the diagnosis, but their whole family, their whole support system. It can get out of control, sadly, quickly. So I want to know, if it's once a month, once a week, and it's just a dog, okay, but you need to call me before your next appointment if it's becoming more often or it's becoming uneasy for you, if it's unsettling to you. And that's when I would suggest taking medication. I get it. Nobody wants to take more stuff. And I don't want to give people more stuff, but I don't want them showing up in the emergency department. I've had some unpleasant experiences, unpleasant for me, but way unpleasant for my patients and their family members. In terms of police being called, I had to have, somebody had to be taken out of the home. I've had a couple of people who took out guns to protect themselves from the hallucinations. You don't want that happening. You don't want things getting to that extent.
And I'm glad that you brought that up, because there is a level of safety that I don't know that we talk that much about. I mean, we talk about the importance of if you're having these and they're uncomfortable to see or experience, or, the care partner is really struggling to manage their loved one if they've lost insight, and how to even navigate all that. But, when you get into the delusional behavior aspect of it, I think it's important for us to talk about, the safety things. Also heard some stories that are kind of scary, and there's a lot of maybe shame or stigma around talking about these things, but it is, a very important conversation.
You just don't want them to get to that point, and we have methods to avoid them getting to that point. Again, I have had people who themselves call the police, and that alone was not disastrous, other than it was disruptive, and all the neighbors were looking out the window at 3 o'clock in the morning at the police car outside somebody's house. But I have, sadly, still disturbing to think, one of my patients was a retired physician who assaulted his wife and had to be removed by his wife calling the police because he was a threat to her. Don't want that to happen again to anybody. Nobody wants that to occur. I'm not saying it ever would. That's an unusual example, but that is somehow how it turns out, that things get out of hand, that people feel threatened, and they respond in a way that makes sense to them. They're going to protect themselves from that person who looks like their wife, sounds like their wife, but it's an imposter. Or there are strangers outside waiting to break in and hurt me and my wife. I'll take out my gun and protect our home, which kind of makes sense in that perception, but it's dangerous. People can get seriously hurt. So I try to remember to tell my patients, or ask them, do you have guns? If the answer is yes, are the guns and the bullets separated? Are they locked up? Because if not, they should be.
And I'm glad you brought up I guess, a little rare, the imposter syndrome thing, because that can get very difficult. I know a lady who had that experience, and she would say, every time I go into the room, my husband would ask, well, which version are you? Are you the nice one? Are you the mean one? And so I think a lot of family members, care partners, are not really sure, how do you navigate someone? How do you address that? What should they be doing? Do they go into the experience with them? To calm them down? What do you do to guide care partners in navigating somebody who might be having a hallucination, and or if they're in that delusional behavior where they believe that someone is, trying to be out to get them, or their loved one is cheating on them, or someone is breaking in and wanting to harm them, and then they get agitated?
Well, how do you convince somebody that what they know in their heart is true is not true? You can't. If somebody says, I'm seeing an elephant in the house, my recommendation to respond to hallucinations is that no, that's a symptom from Parkinson's disease. There's no elephant in the house. There's no stranger outside. I've looked. There's nobody out there. This is a symptom you're having from Parkinson's disease. The delusions are tougher. Fortunately, they're not as common as hallucinations in Parkinson's. They're more common in Alzheimer's than hallucinations. But the delusions are tough. I've had many conversations. No, your wife is not having an affair with a 90-year-old neighbor. Well, I've got evidence. I found them I've seen them. I found evidence in the house. It's very hard to convince people. I think in that circumstance, a medication change, or maybe introduction of a medication, is warranted. It's going to be very tough to convince people that what they know in their brain and in their heart is true is not in fact true. I've had the conversation many times. I've had people in my office, say, well, I see animals, right? It's hard to say, well, they're not there. I do tell people, no, the hallucinations are not present, and change the conversation to something of interest to the person with Parkinson's disease. Have a discussion about whatever they like to talk about, and try to move on from the hallucination.
And it is certainly a stressor for care partners that might be experiencing their loved one accusing them, or just, being agitated and not being able to calm them down. Or, sometimes I've heard stories of them just being exhausted because their loved one is getting into things and doing things, or, their behavior is agitated because of the hallucination, and therefore they're not getting any rest because they're either redirecting or trying to, interrupt their mindset at that moment. So it can get very frustrating. And we just had a question, and I have several, but I think this ties in, like, people want to know, like, what's the percentage of people with Parkinson's that actually suffer? I know you showed some statistics, but what would you say the general statistic is of people with Parkinson's getting hallucinations?
Depends on who you read. I did a review in my practice in the past because I record these in the charts, and it was 30% of my patients. And I think I'm pretty careful with medications. Other people reported higher. I think, again, I ask every patient every visit if they're having them. And I think 30%, at least in my experience, is fairly realistic. Some people say it's higher, 50%. And again, in the Australian Sydney study for people with Parkinson's for 20 years, they reported 75%. So I would say it's somewhere between 30 to 75% people have. It's not rare, it's not uncommon that these things occur, and it should be part of the discussion, in my opinion. For those of us who are seeing people with Parkinson's, it should be part of the routine discussion. Have you had falls? How are you doing in terms of dressing and undressing and just daily activities? Are you having hallucinations? This really should be part of the discussion. Sadly, it is not, even though it's a well-known symptom, has been identified for a generation or more.
And is there anything, I know there's treatments, but is there anything that you can do to kind of slow the progression of the hallucinations once they start?
We can intervene with medication or cut back on medication, or again, if there's an infection, treat that. But the hallucinations, we know, have a pretty good idea where they're coming from in the brain. That has been studied both by imaging, specialized brain scans, and also by looking at people's brains after they passed away to see what changes are occurring in the brain in people with hallucinations versus those who do not. And it's thought that, at least in some people, this is evolution of the diagnosis. This is evidence of the pathology encroaching upon other parts of the brain that contributes to the hallucinations. So far, sadly, we don't have a method to stop that evolution. That is the great hope, that we will have some method to halt this diagnosis or reverse it eventually. There's a lot going on in the field, and even at this point in my career, I remain optimistic.
Well, that's always good to have a little bit of hope. Now, COVID, when it was, happening and people were having the loss of smell, some people had strange smells. I actually experienced the ashtray smell and a dead animal smell as my scent was coming back, my ability to smell is coming back. Is that the same part of the brain? I know it's not the same reasoning, but is that the same part of the brain that is being impacted?
Hopefully not. So COVID got a lot of interest among people who are involved in movement disorders, because, as you may be aware, there was another epidemic at the turn of the last century, a influenza epidemic, and some of those people developed, they had encephalitis with their flu infection, and some of those people developed Parkinsonism. Those were actually some of the people that were studied initially with levodopa. I think it's too early to tell whether COVID is going to bring out a new bunch of people with Parkinsonism or Parkinson's disease. Time will tell. It's affecting the olfactory pathways, the smelling pathways, the virus is, but I don't know if it's just in the more peripheral areas or within the brain itself. I don't think that people know the answer to that yet.
Interesting. So, and I love that you talked about some of the experiences. Had a few people talking about that burning smell. Somebody said they smell burnt toast. Is burning usually the scent people experience?
Yes, in my experience, it is. I was trying to think when I was developing the slides, what else have I heard from people? I don't think anybody said, I smell something pleasant, like a pleasant aroma or a fragrance of a flower or something like that. I don't recall. People have sometimes they just smell something strange, but I don't recall anything pleasant being described. I could be wrong. I'll have to pay more attention going forward.
Well, and it's interesting when you shared the example of the person who was hearing Christmas carols in July and they're Jewish. And I knew two guys and they both heard opera. And one loved opera. So it was very pleasant for him. The other hated opera. And so it was really annoying. So I mean, is that a possibility that it can be pleasant? Like it's not always sounds that you don't like to hear, because obviously this person did have that pleasant experience, but it sounds like some people are experiencing something that would be annoying.
I saw somebody not long ago who was hearing, it sounds ridiculous, but it was driving him nuts. Those people who are my age might remember the Mickey Mouse Club, MICKEYMOUSE, Mickey. He was hearing that over and over and over, and that was not good. And it would change to something else, but equally unpleasant, this sort of repetition of something that was nonsensical. And I think the people who were hearing opera, I mean, I like opera, but not all the time. I mean, or inappropriately, I like to sit in and listen to the opera, and not necessarily if I'm engaged in some other activity. It would be distracting and it would be unpleasant. Don't want to hear Puccini if I'm trying to concentrate on reading something, for example.
Exactly. And then we had a really good question, and this has come up before, is how do you differentiate between vivid night dreams and a hallucination?
That's an important point, because hallucinations occur during the waking state. And the transition sometimes from sleep to wakefulness can be long and difficult for people with this diagnosis. And it seems sometimes the dream content will continue while people are waking up. They're still in their dream, but their eyes are open, they're responding to their environment, but the dream has not yet stopped. I wouldn't categorize that technically as a hallucination. So that's an important distinction. So when hallucinations occur, people are fully awake and they're engaged and they've been awake for a while, not just waking up and or certainly not fully asleep. And different also is something called REM sleep behavior disorder, which is pretty common to people with Parkinson's, and may precede the motor stuff by a decade or more. And that's where people are dreaming and they're acting out. They're fighting with an intruder and they're throwing punches, or I had somebody recently, not long ago, she had somebody visiting. She lives alone and had somebody visiting over the Christmas holidays. And her visitor said, "You were screaming loudly last night." She wasn't even aware that she was doing that. That's not hallucinations, but that's what some people feel may be something that goes along, or maybe a predecessor or indication that people are at risk for developing hallucinations in Parkinson's.
And that was going to be my question: is there a correlation to that, to potentially developing?
Some people say yes, other people say no. But that symptom of REM sleep behavior disorder has gotten a lot of attention over the years. That was first published in the late 90s by a couple of guys in Minneapolis. And it's been increasingly recognized as something that can occur in some people very early, again, years before tremor or slowness or change in walking are evident.
And then we have the last question. Somebody's wanting to know about Nuplazid, if it really does help with all these different manifestations, not just the visual or the audio.
Yeah, I would say yes, it does, but nothing is 100%. It has been found to be, in the study that I participated in, the clinical trial that led to the approval years ago. We were not looking at the rarer hallucinations like the tactile; those were not included. But yes, for things like visual and auditory, we think it's going to be helpful. And I've found, as I published in those two cases, it can be helpful with these delusions of misidentification, for example. Nothing is 100% effective. Nothing is going to work for everybody all of the time. But it's thought that it does. I mean, it was developed specifically to go after the parts of the brain that we think are the source of the hallucinations or the psychosis symptoms.
I knew I said that was the last question, but I have one more.
All right.
The last one, I promise this is the last one, but someone wanted to know if there's a link between hearing loss and auditory hallucinations, or can that cause it? That
is an interesting question. And I don't know for sure the answer, but the reason it's interesting to me is there's something called Charles Bonnet syndrome, where people are losing vision often because of macular degeneration or some other process, and they have visual hallucinations. So the brain starts filling in visual phenomena when the eyes are not functioning properly. I suspect that, yes, there is something similar in hearing loss, that there would be some filling in of auditory stuff when people are losing their hearing. I don't know if I'd have to look. I'm guessing there, if I look in the literature, I'll find something. It may not have a name like Charles Bonnet. Maybe it's Susan Smith syndrome, that where people have auditory hallucinations when they're losing their hearing. I bet that is described.
Well, this has been absolutely fantastic. I've learned a lot today. I know that we had a lot of really good questions. I think we got through most of them, but you did cover a lot of material, and I appreciate you highlighting some of the lesser experienced or discussed hallucinations. So thank you for sharing that expertise. And again, those lovely pictures from Iceland.
Well, thank you. Happy to participate today, and appreciate all the interesting questions from the participants.
And in PMD Alliance style, I'm going to invite everybody to give you the wave of gratitude. Thank you so much, Dr. Hermanowicz. As always, really appreciate it.
Nice to see everybody. Happy to participate.
Right. And thanks everyone for joining us. Take care.